Bienvenue à tout le monde. My name is Sari Tediver, and I am the chair of the Interpares Board of Directors. Je m'appelle Sari Tediver et je suis la présidente du conseil d'administration d'Interpares depuis une heure. I just have a few comments, a few thank yous actually as well. We'd like to thank the Douglas Coldwell Foundation, you may have seen a sign outside, who provided a grant to help support this event, and particularly Dr. Melgar's presence here tonight. Their mandate is an especially good fit with our subject of health and humanity. The Douglas Coldwell Foundation was established in 1971 with Tommy Douglas, Canada's paradigmatic advocate for universal health care, as its founding president. It seeks to promote education and research into social democracy, and Tommy Douglas hoped it would be, quote, a gadfly to provoke discussion. In that tradition as well, Interpares seeks to create spaces for critical learning and discussion that cross global boundaries. Whether it is bringing farmers together from India and Africa to share strategies and practices about sustainable agriculture, or convening a round table of women from Latin America, Burma, Canada, to explore ways to confront sexual violence in armed conflict, we seek ways to identify the deep commonalities, including the global processes at work and the lessons learned from different contexts. We know we can learn from each other, consider, adapt, and sometimes reject what others have done. But a critical insight from somewhere beyond ourselves often forms the basis for important action. Health is, as we all know, an issue of universal concern. It is about our bodies/minds. It implicates who we are as biological, social, gendered beings, and the social determinants of health. Are we born rich or poor? Do we live near an industrial waste site or not? Are absolutely critical to our well-being, susceptibilities to illness, and to our resilience and struggles. The quality of our healthcare system is a determinant of individual and population health. And Interpares is very pleased to create this space tonight for such crucial discussion in a Canadian and a global context. I'll now ask Rita Morbia to make some remarks. Thanks.
Thank you, Sari. My name is Rita Morbia, and I am the Executive Director of Interpares. I want to welcome everyone here today, and I want to thank you for coming out tonight. I've had the privilege of collaborating directly with both Dr. Junice and Mike, and I can assure you that we are in for a great evening. We will be presented with interesting facts and figures, with thought-provoking analyses, and with compelling stories. They have decades of experience as seasoned activists between them. In today's exploration of health and humanity, I see a direct relationship with what we have called the right to be. Interpares' action is rooted in the principle that every person has the right to be. This right implies that every person and every community has a right to a quality of life that is human and humane. Every person and every community has a right to live decently and with dignity, and to develop their authentic human capacity and qualities. This right to be includes, at a minimum, the right not to be killed by the state or its military proxies. It means the right not to waste away from malnutrition, the right not to die from disasters that the simplest precautions could prevent, or from wars waged by despots against their own people. It means the right not to die from diseases that are easily preventable. But the right to be goes beyond this right to live with a minimal degree of physical security. It also includes the right of all citizens to be free persons, to be thriving and growing individuals, to be full participants in a free and equal society, to resist oppression and to promote justice. It is the right to become what we can and seek what we dream. Interpares initiates and supports actions that promote the right of all persons to be fully human and achieve their full potential. and to live creatively and actively as citizens in their communities, their countries, and their world. Strengthening people's efforts to recapture their active citizenship and influence social, economic, and political structures that govern their lives remains our central focus, as does working in common cause with people's organizations around the globe. Now, there are many ways to look at health. Inter-Pares sees health as a social justice issue, and we work on domestic health issues through our support of and involvement with the Canadian Health Coalition, just as our international efforts include supporting Likhaan's work in the Philippines. In thinking about how we frame health as a social justice issue, I was particularly struck by comments made during the Canadian Health Coalition's recent Day of Action. Dr. Jeff Turnbull, who's Chief of Staff at the Ottawa Hospital, spoke about growing social inequity and its impact upon the health of all Canadians. His remarks for me showed two things. One, that we have more in common with the Philippines than we would like to believe with respect to healthcare. And two, that health is fundamentally linked with issues of equality. I'm going to quote Dr. Turnbull at length, so please bear with me. Quote, Canada stands 12th out of 17 comparator countries in terms of the gap between the rich and the poor, and this is growing. Growing wealth inequity leads to growing social inequity, and not surprisingly, to health inequity. It's true to say that the poor pay for their poverty with their health. A healthcare system that does not provide equal opportunity for health or access to health services is not only failing in terms of its social mandate, but is fiscally irresponsible. We know that 1% of those in Ontario who use health services consume 34% of all healthcare expenditures. A large proportion of these individuals are vulnerable, poor with chronic diseases, they lack support, and often have mental illness and drug and alcohol addiction. He went on to say, these are my patients, the homeless of Ottawa whose use of the healthcare system is both ineffective and costly. As you drive from the most wealthy part of Hamilton to the poorest, a drive of 15 minutes, the life expectancy drops 21 years. The prevalence of tuberculosis is higher on some First Nations reserves than where I work in rural Bangladesh, and the lung cancer rates amongst the Inuit is amongst the highest in the world. He said, we should not be proud of this, not in a country as wealthy as Canada. We have not delivered on the promise of a universal healthcare system that reinforces equity as an important Canadian value, and in fact, it seems that we are farther away from this than we have ever been. But there is hope, and I believe that a strong, publicly funded pan-Canadian healthcare system that promotes health and provides healthcare to all Canadians is possible. It's within our grasp and should be our legacy for our children. And that's where I'll end his quote. As Dr. Turnbull's remarks prove, health is about equality and it is about justice. One of our goals here at Inter-Pares, as Sari mentioned, is to share stories of domestic and international social change movements with Canadians, to inspire and build awareness of the commonalities between struggles at home and abroad. This is certainly what we are attempting to do tonight. We hope to dispel the notion that there is an us and a them, and foster the idea of a we, breaking down that first world, third world, that north-south divide. We believe that we are all social justice activists working on our own terrain, but together towards a common goal. On several occasions, I've been with Dr. Junice in the Philippines, visiting the communities she works with. It has been a privilege to witness both her expertise and her compassion. And I've been with Mike in all kinds of meetings with important decision makers and the Canadian Health Coalition's grassroots constituency. It is only one of the places that Mike shines as an activist. He is strategic and clearly speaks from a place of deep conviction. I have a great respect for them both and for their many, many years of dedication to social justice work. So just before I turn it over to my colleague, Catherine Dingle, I want to thank you again for coming, and I hope you enjoy the evening.
So to give you a sense of a bit more of where our speakers are coming from, I want to tell you a little bit more about each of them. Dr. Junice is a lifelong activist. When she was in high school, she joined the struggle against the Marcos dictatorship in the Philippines. And while she was studying to become a doctor, she spent time providing healthcare in the remote countryside, treating people who had been impoverished by government neglect and also traumatized by the conflict. And during these years in the resistance movement, Junice realized that women were especially affected and terrorized by the regime, and also that deep-seated patriarchal attitudes lay beneath the radical discourse in the liberation movement that she was part of. This is in part why, in the post-Marcos period, Dr. Junice and other health activists that perhaps some of you have heard speak, Guy is an example, another counterpart who was here a few years ago, they created and formed Likhaan, a space for women to share their experiences, to develop and assert their ideas. And it was through that organizing and training women in slum areas that they created innovative, community-based women's health programs. So you fast forward 20 years, and she's still there with Likhaan. And although she spends quite a bit of time on Likhaan's administration and securing funding for the organization, trying to convince the Filipino decision makers to make wiser choices on healthcare issues, or flying around the world to attend high-level policy meetings on maternal and reproductive health, she remains a doctor and practices a little bit when she can at the Likhaan clinics. And we've joked yesterday that this busy work week in Ottawa will be like a holiday for her compared to what a regular week is like in the Philippines. So happy holidays. And then Mike. Mike is also a lifelong activist. He has headed the Canadian Health Coalition since 1995. So that means it's been almost 20 years that Mike has been bringing together people and organizations united in their concern for fair and accessible health in Canada. And he has the exciting but probably difficult job of representing seniors, women, churches, nurses, healthcare workers, anti-poverty activists from across the country, bringing them together and then attempting to grab the ear and the attention of decision makers to make wiser decisions. He has been doing this, as Rita said, with incredible dedication and commitment. And I also heard a rumor that he throws a really good St. Paddy's Day party. So I guess you have to know how to have a good time in the midst of all of that. So we're going to jump into learning about health and humanity. Both guests are going to start by giving us a bit of an introduction to both their respective organizations and also the social and political context in their countries. And then we'll do sort of the interview style of questions back and forth. So I'm going to invite Dr. Junice to start us off with the international context and take it away.
Because in the Philippines, actually, when we study universal healthcare, one of the models that we study a lot and have great admiration for is the Canadian health system. So that is a surprise. I remember even Michael Moore cited that compared to the US, Canada's health system is one of the greater systems. And that is how we still believe it, because the Philippines, I'm reminded by our great links to the US because President Obama is visiting the country today and meeting a lot of the activists there. But we have very, very close ties with the US. As you may know, we were like a colony of the US, Filipinos wanting to be the 52nd state of the US, so that our healthcare system is very much like the US. It's semi-private. The estimate is that about 50% of facilities and probably even more of the doctors are private practitioners. And that means that a lot of them are really not controlled or regulated by government. Government has like half of the beds and facilities. It has the hospitals are bigger and therefore the beds are more. But actually you have equal capacities of the public and the private sector. That means that our health system is basically just semi-public. And so you have that fragmentation between private and public. And you also have fragmentation within the public system. So that you have a national government that provides hospital services that are quite detached from the services that are being given at the local government units. And the local government units, we have like 1,500 of them, all totally autonomous. So they're not considered under the jurisdiction of the national government system. They can devise their own policies. So the healthcare depends actually on the locality. For example, if you live in the district of Makati, which is like the financial district, then you really have wonderful benefits from outpatient to hospital care. You get a lot of privileges. The senior citizens in Makati, they get cake and special privileges every year, but only up to the boundary of Makati. Makati is surrounded by the poor people, but poor people, even if you live next door to Makati, you cannot access the kind of health system that Makati gives to its citizens. I would compare that also to Manila. Manila is the old city, the old capital. I think it's a very romantic place. And it's also a place where they are very generous to women, so that all deliveries, all maternal health care in Manila is for free. And they have good hospitals, except that Manila has denied contraceptive services to women since 2000. And no national government could actually force them to say contraceptives are part of the standards, not just in the Philippines, but all over the world, and that Manila should adhere to the standard. Manila, until now, actually refuses to provide contraceptives. So healthcare in the Philippines depends on where you are, or what kind of local government unit you have. So even the content, the range of services, we say in the Philippines, at the primary healthcare level, we have 8 basic services. You have pedia, nobody fights about pediatrics. Then we have maternal care. Some local government units, they provide birthing care, but in some other units, they just provide antenatal care. And in the Philippines, where women die actually during delivery or around the time of delivery, that means these women deliver outside of healthcare. So they're delivering with untrained birth attendants, or they're probably delivering by themselves. So this makes a lot of difference, the kind of services. And also, not just the kind of services, but the effects of politicians on healthcare. So that if your hospital is funded by a congressman or a senator, funds that hospital, then the voters of those elected officials can actually get priority in that hospital over the others. So that even, and the doctors actually are the ones complaining that they say, we get a lot of patients from this politician, even if they're not sick. So the politicization of a very fragmented system is like they're twins. They cannot be separated from each other. So there's politicization. And then, of course, in the Philippines, I mentioned this when I talked about Manila, contraception is not allowed in many localities. So you're lucky if the government allows it, luckier if the government funds for it. But if there is no contraception like Manila, then you can have as many as 22 children and not being able to, let them have quality life. So that's the problem of healthcare in the Philippines. And this government, actually, the new government from 2010 up to 2016, is like a center government. He tried to do reforms, like he calls his reforms actually universal healthcare reforms. And this basically consists of subsidizing the insurance, the social health insurance of the poorest. So they've covered the poorest quintile, like that's 20%. And they're trying to do now the insurance of the second quintile, like 20%. But the benefits of the social insurance leave lots to be desired. So I will talk about that later if you have. So being insured does not mean much, actually. For one, there is no prepayment at this point. They charge you and then they just reimburse your expenses after. Good if you're reimbursed fully, but sometimes you're not. No? So if you're very poor, it matters a lot. The other reform is that the health budget actually increased under this. The health budget of the Department of Health or the national government increased significantly, except that in a fragmented health system, it doesn't matter much because the main provider of primary health care are the local government units. And you don't actually see how much the local government units are allocating. You only see their allocation after the fact. So that's a problem with 1,500. So it's a big systemic problem, actually. We don't know how far the vision of this president is in changing the actual structure of the healthcare system. My organization tries to work with them. We try to work actually with the Department of Health, clarifying the health systems, clarifying the effect of devolution and extreme fragmentation in our system, which actually means that even if you budget a lot, it's like the budget will probably just be dispersed and get lost. No? We actually also work with the local government units where we run community-based health programs. Community-based health programs are a variety that you can find only in the Philippines, no? Since the 1970s. It is a product of Catholic intervention, actually, in health. These are products of social justice programs of the Progressive Catholic Church of the 70s. So you have community-based health programs run by, basically by volunteers, but volunteers who are trained to act like doctors. So they're trained basic diagnostics, even minor surgery, etc. They run hospitals supervised by doctors. And they don't just treat patients, but I think what's very important about community health workers is they address the social determinants of health. They address poverty. They address social services like the lack of water, the lack of electricity, a garbage problem, gender problems like battery, and, for example, the discrimination against women who have abortion. So all that kind of stuff, community health workers usually are trained. No? Our community health workers are actually trained to act like little doctors in their community. The good news probably is that these community health programs are being recognized more and more by government, by non-government organizations, so that our community health workers have been asked when there was this big typhoon in the Philippines that hit last year. We were actually requested to deploy 12 of our community health workers to help in the recovery of one of the biggest hit provinces, which is Eastern Samar. We get invitations from other local government units to actually bolster what they call the demand for health, the health-seeking behavior, the appreciation for health of people, so that they can match what the people need with what the facilities, what the providers are giving. So that is basically what we do, and maybe I will talk about the much more known advocacy for reproductive health care.
Save it for a little bit later.
A little
We want to
bit
save
later.
that story.
Yes, that is a good story to tell.
Thanks, Catherine, and it's a pleasure to be here with Inter-Pares. I mentioned with Karen Seabrook that when you reached out to us about 10 years ago at the Canadian Health Coalition, that was an amazing alliance that was built in a partnership greatly appreciated. We're much stronger through our relationship with Inter-Pares, and it's a real delight working with all of you. I feel very humbled being in your presence. I'm not a celebrity by any means, but I love the title of the session, Health and Humanity. Very powerful title. It's interesting, in a lot of cultures, there's no word for health. Health is an abstract construction. I read a book that talked about how the Cree in northern Quebec look at health. And I remember talking to a nursing class at Algonquin College and quoted this elder who said, "How can we be healthy if the land is not healthy?" Because in the Cree language, health would be a series of words that communicated the notion of being alive well. And being alive well meant you could rely on the country food. It meant a whole series of chain things that are connected. So health as a word in isolation means nothing. And so it's a very radical question to ask, how can you be healthy when the land's not healthy? And so it challenges our notion in a Western capitalist country that health can be a personal, individual commodity. That's ludicrous. Now, what was interesting when I mentioned this to the students, one of the nursing students came up to me and said, "What was the name of the elder?" Because I'm from that community. So you never know who you're talking to. And in that book called Being Alive Well, I wrote this quote from Charles Dickens, Hard Times. "And what you couldn't state in figures or show to be purchasable in the cheapest market and saleable in the dearest was not and never should be, world without end. Amen." The reason I wrote that quote in this book is because there's certain things that don't belong for sale in a market. And basically, I've been lucky to devote my life to those things. It has no market value whatsoever. And I thought about it in terms of, as I age, I look back from family origins, history, ancestors, and I realized that I came from people who were total market failures. From extremely wild areas in the west of Ireland and extremely poor areas in the Scottish Highlands. And the English at that time, we're talking 500, 600, 700, 800, 1,000 years ago, complained that these wild peasants didn't know how to deal with the market, and therefore were inferior civilizations. And so I've come to value not being successful in the market. Because the link is obvious with healthcare. Healthcare is clearly not a market commodity. Even though we're in systems influenced by that powerful ideology that everything's for sale, and that wants to treat healthcare like the American system does. That if you've got the money, you can get too much healthcare. If you don't have the money, you don't get enough healthcare. And these issues have really come to the fore in our country right now, I think, because the Canadian Health Coalition was formed in 1979 in response to a crisis at that time, which was doctors' extra billing. Does this sound like Groundhog Day? And it was a really serious problem because we did have public insurance, but it was being undermined by doctors charging patients illegally. And so we were fortunate at that time, the Canadian Labour Congress convened this conference and invited Tommy Douglas to come, and Justice Emmett Hall, and McBane. So these were three pioneer figures in public health care in Canada, active in three federal parties. So this was not a partisan issue at that time. There was a point in our history where you had three federal parties that actually believed in public health care. If you're old enough, you'd remember that. Young people today would probably find that strange to say that all three federal parties believed in Medicare. And the resolution from the conference was we needed a coalition. We needed to form a coalition. And so that was the birth of the Canadian Health Coalition in 1979. There's a video of part of that conference with Tommy speaking and others speaking, and it's a scream looking at it because there's people in the audience smoking. I thought, wow, that's, there's progress after all. And so the first campaign was to stop extra billing. It took us 5 years, and we were successful with the Canada Health Act. That's why we have the Canada Health Act, because there was a campaign for it. And I remember the minister responsible, McBane, would often say that. The reason that she got this through cabinet was she was able to point to social forces and social movement and citizen pressure. And that's what allowed and enabled the political agenda to move forward. So if I only had 30 more seconds to describe the Canadian Health Coalition, I'd say that was our first achievement, to outlaw extra billing with the Canada Health Act. And ever since, 30-some years later, we've been working to maintain the enforcement of the Canada Health Act. It's very simple. We fought to get it. Now we're fighting to keep it enforced in terms of, because what the Canada Health Act symbolizes is that healthcare does not belong in the market. Healthcare in Canada is protected from the market by the Canada Health Act, which says access is not based on ability to pay. That's not a market concept, which is why market ideologues hate Medicare, and they hate the Canada Health Act for having such a subversive notion that you have a right to a basic social service regardless of your ability to pay and regardless of where you live. It's a very huge social achievement for Canada, and Canadians are proud of Medicare. Medicare's been very successful. You don't often read that or hear that, but it's a huge success story. And I remember some people were talking about the history of the Canada Health Act, and it was important to remember that it was opposed by the Canadian Medical Association. It was opposed by most provinces, most media. But what was interesting, everybody was against it, really, except the people of Canada. And that's why it's such a strong political symbol, is that the elites are not responsible for its birth. It didn't come from corporate boardrooms. It came from kitchen tables. This was a bottom-up organizing that started locally, spread to an entire province of Saskatchewan from Swift Current Health District No. 1, that formed a co-op. And that was the beginning of a good idea. And then the country adopted it. And now it's a very powerful idea, because Canada, because of this public insurance, spends 50% less than the United States for healthcare. And everybody's covered. And we happen to live 3 years longer than our American neighbors. Now, that's not a bad comparison. So it's not all bad in Canadian healthcare. It is a success. However, the original vision was to have a much broader system and to have a system based on prevention and promotion and community health centers. And there were some fundamental compromises made for the first phase of Medicare. I went back to the Canadian Health Coalition's brief when the Canada Health Act was being discussed in committee. And one of the criticisms the Canadian Health Coalition had was that the Canada Health Act was too focused on medical care. It wasn't comprehensive enough. It wasn't dealing with the social determinants of health enough. And I remember Monique Bégin acknowledged that was a flaw, but that's all they could get at that time. So we've got one phase of Medicare. Tommy Douglas called it phase 1. But what we need now is phase 2. Phase 2 is what the original vision was, to make it more comprehensive and more a continuum of care. So your care follows you when you leave the hospital. Right now, if you leave the hospital, you don't get your chemo treatment unless you pay thousands of dollars. Now, just think of the perverse incentives for a healthcare system that forces you to be in a hospital bed to get free medication. And so we need, obviously, to expand the system to include pharmacare, to include a national public drug insurance system. Now, a lot of people, I won't spend time on pharmacare right now, but a lot of people would argue, especially politicians, they'd say, well, how could we ever afford that? And the answer to that is we can't afford not to have public insurance for drugs. Because if we brought in a public insurance system, we would save at least $10 billion a year by consolidating all the fragmented pieces, and by having bulk purchasing, and by eliminating profit, and by having a better quality prescribing, that we would educate prescribers to have much more evidence-based focus. And so that's the next phase, pharmacare and home care, and having the care follow you to where it's needed. And that, of course, has a major community focus. And the best example of that are the community health centers. That's phase 2 up and running. But it needs to be supported in a much broader way in a national system. And, of course, Medicare 2.0, or the second phase of Medicare, cannot happen without the federal government. And that's where we are today. So the federal government is withdrawn from healthcare and has said healthcare is provincial jurisdiction. And of course, that's completely false. Healthcare is a shared jurisdiction. And we know, and Canadians don't buy that line. Canadians know there's a strong federal role for healthcare, and Canadians want a system that works well to be improved and to work better by having more insurance for the pieces that are not covered right now. And so I think it's important to not get backed into a corner to defend problems in the healthcare system, but also at the same time, not to paint too dark a picture. That Medicare actually is a miracle. We have to keep it going. And the best way to secure its future is to grow it, to have more Medicare.
So before we get another step 2 into sort of the healthcare systems discussions, I want to go back to Likhaan because it's really an incredible counterpart in the Philippines. And I want to make sure people understand just the scale of Likhaan and what a role it plays in the Philippines. So I wonder if you could explain, Dr. Junice, if I were a woman from a poor community in the Philippines and I happened to have the good fortune of there being a Likhaan clinic in my community, what kind of programs would I be able to access there that otherwise would be absent? Could you tell us a little bit about the clinics and how they're present and running in the communities?
Likhaan is not all over the Philippines, but it's in 4 big cities of Metro Manila. The capital city, Manila, Quezon City, Pasay, Malabon. So these are also cities that are rich, but with a lot of poor communities. So we work we have community-based clinics that are focused on women. So it's women and whoever is their significant others. You can go to these clinics. Everything is free. We provide diagnostics for general medical problems, but we don't provide services. We would refer you to a higher facility, actually, if you need further care. The 60% of the services there per demand of the patients are reproductive health services, meaning maternal care. We do not provide birthing, but we can refer you to a government. Usually our referral points are government hospitals or centers whose quality we know of, because we deal with these providers. We actually help to educate providers in these referral centers on what we call rights-based care. So what we cannot provide at the centers, and there are 6 centers in the big cities of Metro Manila and in 2 provinces outside of Metro Manila. It makes use of the referral, although very fragmented. But what we make sure of is that we know we are identifying centers and hospitals that Likhaan patients can go to. So the clinics are, we have like 8, these are not doctor-run clinics. These are run by nurses and midwives. So there is a lot of task shifting, actually, in these clinics. But this goes very well also with the WHO proposal now that in countries where you have scarce resources of doctors, actually we have lots of doctors, except that they serve people outside of the Philippines. You know, they migrate. The great brain drain. So we are left actually with nurses and midwives who actually can function very well at the primary healthcare level if they were trained to do so. And that is what we model. So we have those primary healthcare practitioners, but they are supported by community organizers, like Obama. Remember Obama, the great organizer? We have better organizers in the community. Our organizers actually link the very poor people who are usually very timid, very afraid to be discriminated against, to be shouted at, you know. Our hospitals are known to be like torture chambers for the poor, you know. If you don't have money, then you get very, very bad treatment. So that we also educate the providers about rights in these referrals. And the community health workers actually navigate the health system for the people. They identify which centers, they identify how much, they actually help raise money. They bring, and this is very important in our communities in the rural areas, where the women live up in the mountains. The community organizers actually bring down the pregnant women from the mountains, make sure that they deliver either in a facility or bring them to a hospital. So even the doctors in the hospitals, they know. When it's a Likhaan community health worker that goes to the hospitals, they know that these patients are poor, that these patients need assistance, like whether it's intravenous fluids or blood or a doctor right away. So it's circumventing what is a very dysfunctional system right now, but it's also modeling, I think, a care that is possible in our setting, that you have activist health workers actually radically invading the health system and making sure that the health system works for the poorest women and their families.
We've already heard many examples of challenges that exist in both the two different healthcare systems. So, fragmented system in the Philippines where there's a lot of public, but also a lot of private and people paying out of their own pocket. In Canada, Mike, you identified the lack of national leadership to bring the Canada Health Act into a greater phase 2 to protect and enforce that act. So I wonder if maybe let's go there. Let's talk about work that Likhaan and the CHC are doing to address some of those challenges. And maybe this is a chance where we can talk about the Medicare tour or the incredible work around lobbying for the reproductive health law recently.
Let me talk about the reproductive health care because it's one of the bigger successes of Likhaan. Reproductive health has long been denied in a country that has never allowed abortion and almost wanted to illegalize even contraception per the dictates of the Catholic Church. So the Philippines is a very Catholic country. We have bishops there actually dictating on health, especially the health of women. And they have actually found an ally in a president of ours. Thankfully, she's gone, but she ruled the Philippines for 9-10 years and actually allowed many local government units to disallow family planning, so that even the national government at this point in time, for 9 years, was promoting only natural family planning, you know? When you get your mucus and you stretch it every morning, and then you try to convince your husband that I'm fertile today, you cannot touch me. So for the longest time, it's really funny that the Philippines was promoting that kind of family planning as the main service of the Department of Health. And so the battle for reproductive health actually took root there in 2001 with this president. And it went through 4 congresses. So it was a 14-year struggle actually to get contraceptives into the healthcare services, the routine services of government. And we were able to do that only with this president now, who included contraceptives, and he calls it responsible parenthood, very much like the way the priests use it. To get services, with this law, actually, all government centers shall provide reproductive health services that includes maternal care and delivery. That will be funded and subsidized by social insurance for the poorest. It will also provide contraceptives. You can have natural family planning if you want it. Even the government will fund natural family planning for the 0.1% couples who opt for it. And of course, the full range of other contraceptives. It also allows post-abortion care, which has been stigmatized in the Philippines, even if it's not abortion. It is something that providers probably would not have anything to do with, but it's in the law now. And all these services, what is nice about it, because we were able to intervene, is that it actually provides a menu of services from the community to the smaller centers all the way to the top. And it also allows social insurance, what we call PhilHealth, to subsidize the poorest. No? So it is a big victory. They tried to diminish. They wanted to hammer in the fact that this is not abortion. So any contraceptive that acts like an abortifacient, I don't know how they can do it, but there is something in the law that says any contraceptive that might act like an abortive fashion, you're not part of the menu. So they tried actually to dilute the law. The Supreme Court did. But I think it's a big win over religious domination of our health policies. So I don't know how this new pope actually will react to the Philippines. But at least in the Philippines, we are saying, at least for contraceptives, they're part of women's health, and that it's a government obligation to provide these to poor women. Yes.
What's interesting too of the work that took decades to bring this law into the Congress is that this is an example of Likhaan playing this multifaceted role, right? I mean, your community health workers are providing care in communities, but it's also an organization that is organizing and bringing people to come together and to lobby and to campaign for these things. I mean, you yourself would have had quite a role in terms of speaking to people in the ministries, and is that right?
At the very bottom of it, or maybe at the anchor of the reproductive health movement, actually are communities that we organized. The first thing that we organized in 2001 was what we would call the primary constituency, the women who would benefit most from the law. So these were poor women in urban communities, in poor communities. These were the ones who were marching to the parliament, to the two houses of Congress. These were the ones that were dying in front of the Catholic bishop's palace. These were actually the women that stayed for 6 weeks in what was our version of Occupy Congress for Reproductive Health. So this was taking place for the many years of the advocacy. And they were providing actually, I think one very significant contribution was they were providing their legislators with actual stories about women who died because of the lack of contraception or the lack of maternal care. And therefore, the primary author of the reproductive health law in the Senate would always make sure that the Likhaan community health workers and leaders were there so that she could allude to them behind her all the time when she's talking about this particular provision actually answers a problem of the women in the community. So they were front and back of this advocacy. And a lot of our community health workers actually were known to media, like the BBC were interviewing our women. They appeared in The Guardian, they appeared in the Los Angeles Times, etc. So they became celebrities like right here because of that. But I think it was a huge appreciation also for what community people can actually do to define what the law is.
And then on the Canadian side, I mean, this is a big part of the work that she does all the time is campaigning and talking to people and engaging communities. And Mike's fresh off a 10-day tour or a tour across the country around Medicare. So will you tell us a story from the campaign or how it went, what the goals were?
Sure. Yeah, it was 17 days, but who's counting? Good to be home. It was an incredibly unique opportunity to see the country, at least 11 communities that we visited. I think one of the things that really hit me was the stories of people telling us about those who are falling through the cracks. And I remember hearing this in Alberta. So this is the richest province in one of the richest countries. And what we heard from is actually a city councillor in Medicine Hat, and basically saying the people at most at risk are young people coming out of university because the jobs have no benefits. And the provincial plan is full of holes, so your pharmaceuticals are not covered. Increasingly, people are falling through the cracks. Another story, also from Alberta, after we had a public meeting, a nurse came up who works in a nursing home and said, "You would not believe what it's like working in a nursing home. You wouldn't feed your dog the food we're feeding our elders." And again, this is in the richest part of Canada. And we haven't even seen the tide of an aging population in terms of when the boomers get housed in these nursing homes, it's going to be a much, much larger population. So we are not taking care of elders right now, and it's totally substandard care, and no plan for the future. And we were looking at some analysis of the decisions that the Harper government made to cut the funding beginning in 2017. And what's interesting about it, is scary, is when the demands go up the highest down the road is when they'll cut the deepest. In order to, so really they're shifting the fiscal burden to individuals and to provinces. In order for what? To buy us in the next election with a tax cut. And the level of sabotage that this represents, if you don't plan for the future, for your aging population, an exploding number of dependent seniors with a lowering of the overall population growth, and we have lots of money, but we're giving it away in tax cuts. We're not planning to meet the needs of our society. In fact, it's like there's no future, no plan for the future. We have a plan to dismantle the federal government. So the objective of the tour is to get the word out of the implications of this planned cut. Cleverly comes after the next election because they're afraid of paying a political price of being seen to destroy Medicare. So they do it by stealth. They do it death by 1,000 cuts, so nobody notices. It's like the frog in the pot of water. And so what we're saying is, wake up, folks. They've already said this is what they're going to do. This is where it's headed. And we have to have a major intervention to get a change in course or change government. And that's really our objectives over this next year. We have a year to wake people up because we know Canadians of all political stripes value universal Medicare. But what we have to explain to folks is you cannot maintain Medicare without paying taxes. If you want to keep your tax cuts coming fast and furious, do you know how much money's lost every year just with the HST cut by 2 cents? $14 billion a year. Gone. Now, has anybody seen what that 14, have you noticed your 2 cents off your Tim Horton coffee? No. But it's noticed in terms of lost federal revenue. That's the problem with it. It's like drilling holes in the bottom of the boat. And so it's to get the word out. It's also to challenge the misinformation that we can't afford public health care. That's ludicrous. You can't afford private health care. And let's face it, you're going to pay for health care one way or the other. But if you pay through your taxes, you get more health care. And those are some of the basic facts we have to get across. And then the third objective is to get people meeting with their federal politicians. The goal of the Canadian Health Coalition is to make sure before the next election that the parties have a serious health platform, which includes a seniors care plan, which includes adequate long-term federal funding, which includes a national drug plan. And I am relatively optimistic that we will get that at least from two of the opposition parties, two of the main opposition parties. So but it will take hard work. That's achievable, and that's part of what our goals are.
I feel like on the CHC website there are a couple things, actions that people can take. do the same, to reach out to federal politicians. And so the CHC website is a great resource for health information in Canada. And I think we have some information about the current Medicare campaign here at the back of the room if you want to take a postcard, write a postcard, all that kind of stuff. Well, Mike, I feel like you just answered what my next question was going to be, which is, what are you hoping to accomplish in the next few years? But I feel like that was it, right? So maybe I'll...
Just a quick response on the postcard. People have been writing their MPs, and they're starting to get answers back. And so people are sending us the answers and saying, what do we make of this? So Aaron and I today, we've just been working on the rebuttal. It's complete misinformation that they're getting from the federal Conservative MPs. And so part of our next stage will be to post the rebuttal to get the facts out and to wake people up. So it makes a difference filling out those postcards. The more they get, the better. So I'd encourage you to take them at the end of the meeting.
And Dr. Junice, maybe you can help us imagine what the next few years for Likhaan will be. What will, as an organization, you be hoping to accomplish and to see change in the Philippines?
For Likhaan, this is because we have been considered, and we consider ourselves one of the leading elements of the reproductive health advocacy network. That means we will be at the forefront of making sure that the reproductive health law gets implemented and that it does not become a vertical service, that it gets integrated with tuberculosis, communicable and other communicable diseases and non-communicable diseases, so that it becomes a horizontal program also of government at all levels. So that is one dream, and we know that's going to be very difficult given the fragmented system. Already under this government, there are signs that they really want to invest in health. They're providing money, they're fixing the facilities, etc., except that under the devolved system, national government can build hospitals and facilities and supply all the drugs there, but the local system provides the human resources. So that is our problem. You can have so many white elephants because there are no human resources. So what we would like to do, actually, with the reproductive health law, because the reproductive health law says there should be this number of human resources and that there should be integrated. So we would like the reproductive law to be the seed of like a more holistic health system, small reform, actually, just making sure that the basic package is there and it's well funded. We will be very happy if three years from now, the first steps would be taken by the national government. Of course, it will take a lot of leadership and political will. I don't really know if the next government will be able to do that. We changed government in 2016. And therefore, even right now, we are making sure that the next government, the next national government, will be favorable, will look favorably at this law. Otherwise, it might die from neglect and oblivion.
That's a topic that we've talked about a little bit, this idea that you need that leadership, and I'm sure that's the same feeling with the CHC, that you need the people, the opposition parties, and the people in power to be promoting and protecting these systems. So we'll be watching in the news and keeping in touch to hear with the new government if the reproductive health law stays where it should stay. So a quick comment to you, the audience, that I've just got one or two more official questions left for Dr. Junice and Mike, and then I hope that if you have a question, there'll be a chance for you to answer it. So there's some pads of paper on the tables if that's helpful. Otherwise, we've mentioned that we think you're both celebrities, and we're amazed by this long-term work that you're doing, but I think it's helpful for people to understand when you are looking at these long struggles and these uphill battles? What is it that sort of sustains you, or that allows you to continue working with your colleagues and to continue challenging the systems that are making healthcare difficult for both people in the Philippines and for Canada? So what's the inspiration or the sustaining?
You want to go first, Mike? Or it seems like a very difficult question.
Yeah, I get asked that several times. So what keeps you going? I mean, one of the dynamics is I feel very fortunate in this work because you're on the side of the angels. And you happen to have ethics on your side as well. And you happen to have about 90% of public opinion on your side. So that helps a lot. So basically, you're just dealing with a small number of enemies of Medicare who own the media. But at least you've isolated your problem. And yeah, so there's been amazing people weighed in on this fight from all walks of life. Rita mentioned Jeff Turnbull. What an incredible person. Talk about emulating the values of health and humanity. It's incredible. And those people sustain you. And in fact, I feel lucky to be able to help because they're really the front line.
For me, actually, the one that pushes me is the community, because the community needs to tirelessly fight for their basic entitlements. And yes, you get swept with that tide and with their fervor. I think it helps that we have good relationships, we have good camaraderie in Likhaan, in the network where we sustain each other, because this is all very upstream. It's a fight to change a health system that's been there since the start of the health system in 1946. So we know that even it will not finish with us. So it's very important that there are young people involved in the struggle. And we, like Mike also, we are very lucky actually that we have mentors in the reproductive health movement, also in the universal healthcare movement. We have a former Secretary of Health who was actually called a socialist, the same way that Obama was called a socialist, but I think that was a little superficial and premature. But the Secretary of Health was actually like a socialist in the sense that his rallying cry for us all the time was equity, 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 that a health system that has no equity is meaningless. So that was his rallying call for universal health care. But he was also like a very secular. He was very Catholic, but he was very secular. And he was the first one to coin the Catholic Church in the Philippines as Talibanic, the Talibans in our midst. So he's very irreverent that way and very courageous, I think, for a Secretary of Health to be upfront and actually calling the Catholic to account for the death of women, for women's, the poor health of families of women. He died, unfortunately. He's a member of our board of trustees, but he died last year. But people know him. People know that he's the inspiration behind us, and he's never dead to us. He's behind every move that the Universal Healthcare Group actually takes. I'm
sure many people in this audience are thinking that he sounds like the Tommy Douglas type person that many people here would think of in that context. So at this point, I'd love to invite you to move to a microphone if you have a question. There's two. There's one here and one just over there. And as Sari or Rita mentioned, you can ask your question in French or in English, and we'll do a quick translation if it's a question in French. I have a question that I will put to you as people run to the microphones. In Canada, public opinion around health is well known. It's something that is a topic of conversation at many dinner tables, walks in the park, and there is a sense of this is a part of our sort of national identity. And I wonder if you can help us understand is there a public narrative? What is the public narrative around health in the Philippines, especially around issues of inequality? How do people feel around the unequal access to care that people in the Philippines have? And is there a sympathetic public in general to the work of groups that are advocates for universal health care?
The poorest people are the ones most conscious of the inequality. Like, for example, they see five-star hotel-like hospitals for the very rich. And in their own health centers, they rarely see their doctors. So they know that very well, except that they're probably too busy with their lives, too busy with earning a living for themselves, that they are not able to take part in the movement. So the movement, the universal healthcare movement, now is actually made up of medical people, medical students, academics, but we need to get the people who are most affected by such a healthcare system, because they know, they are so intelligent, they know exactly what they need, they know exactly what they need to do. So these are not people that are just willing to receive the benefits, they're willing to work for. So that is a narrative that that needs to be created. There is a universal healthcare design, even by the government, even by activists like us, but it needs to include the voices also of those who cannot really afford it, and that is what is lacking in the universal healthcare movement now, which is only about maybe less than 10 years old in the Philippines. It's like, it was started in 2000, so no, it's now 2014, so it's 14 years old, but it still lacks the presence and the voices of the poor.
Well, I have written out a little bit here because I have a tendency to ramble. So having become a more active activist in the last few years, I've been an activist for half my life probably, but I am concerned that it's very hard to convince the reluctant. And I thought that the two activists that you represent may in fact have some comment on, well, I think, Mike, in terms of trying to get enough public support for phase 2 of healthcare is going to be a major job. So what do you say to the doubters who say back to you, like they do to me, oh, Clark, what's the point? It's hopeless.
Well, I don't know if I understood the implication there, but I'm hearing that cynicism is a huge barrier. And I agree that that's a problem. And I think it's a dangerous problem that we need to give attention to. Because in an international context, what's the alternative to politics? Civil war. So people who diss politicians and who say, government, get out of my life, be careful what you ask for. That we have to revalidate politics and democratic politics and democratic debate. I was at Herb Gray's funeral a few days ago, and everybody noted that Herb Gray never attacked anybody, never attacked an opponent, and always respected the role of the opposition to represent opposition and not attack them. And so we've lost so much democratic ground under this vindictive regime. It's so vindictive that some of the founding fathers of this government are writing memoirs saying this is out of control. But the challenge is one-on-one. You have to personalize it and just launch the ball back to individuals and say, no, that's a cop-out. You know there's serious, pragmatic, tangible issues that have to be dealt with, and you have a responsibility not to let anybody get away with that, or to let them off the hook.
Do you have anything you want to add, Dr. Eunice, to that? Yeah? Okay.
The cynicism also, something like that operated regarding the reproductive health law. People were saying, you'll never win over the Catholic Church. The best solution, we were advised, was that to just be quiet about it. Don't fight it. You can just work quietly, convince people. And we said, women are going to die without maternal care, without contraceptives. And I think what validated our position was the many surveys. So survey after survey came after, saying 74, sometimes 80% of the populace actually wanted the reproductive health law. So that was what I think that gave us strength. But I think also the fact that you were fighting for something that was just, and that we had all the medical, the legal, the ethical arguments behind the law. So I think that all helped. It's like the reproductive health was the product of many, many efforts, many sectors coming together, the media supporting us, even government supporting us. And yes, so eventually the power of the bishops ran out. And I think this was the first defeat, that what they really wanted did not happen in a very Catholic country like the Philippines.
Plus now, Mr. Chop, when people say, what's the point? You can say, well, I heard this story about Likhaan in the Philippines and the Canadian Health Coalition. And then they'll be less cynical. Karen, you have a question?
I do. It's on. First of all, thanks to both Junice and Mike. I thought your presentations were excellent. I just wanted to say I've had the privilege of working for an organization with no market value for over 20 years, which is Interpares. So I know you both, and I know you've just sort of scratched the surface of what you could say tonight. In terms of Likhaan is an unbelievable organization. And they have worked at so many different levels for so many years to improve women's health. And it's been a hard struggle. So this was an enormous success. And Janice, I wondered if you could talk a little bit about the coalitions, the other organizations that you worked with. Because I know it's not just Likhaan, but you also reached out and did coalition building yourselves. And I think that's such an important strategy in here as well.
The Coalition for the Reproductive Health Law was built stone by stone. Of course, the first stones were the ones who needed the law the most. So these were the poor women. And it was very easy to galvanize them. So they were like the striking force of the movement. Health practitioners actually rallied around the law. academics to researchers. The tilting factor for the law actually was when government officials, high-level government officials, came out saying, actually, even if they were blackmailed by the bishops, they came out openly. Even the president, our president, who was then a candidate, openly supported the law, even if the bishops threatened civil action against him and to excommunicate him. So a lot of these people that you would not even think would become part of what came to be known as the Purple Ribbon movement. Many, like businessmen, we would not even talk with. I think they came because they knew we were going to win. But the basic pillars actually are the poor, the health professionals, and the health students that were fighting. And maybe what is very significant about this was that this was the one movement where all the political groups in the Philippines that are squabbling. You probably heard of we have a range of political groups, Marxist groups, Leninist groups, etc. All of them came together for the reproductive health law. So it was like the first pillars, but then when the main foundation was there, it just attracted people. And I think the tilting point was when even Catholic officials and Catholic academicians were saying this is the reproductive health law is worth fighting for. So that is a coalition. Actually, people that we did not talk with, like we're not particularly religious, but we were talking with some religious people. We were talking with Catholic priests. And we know that thousands of them supported but could not openly say so, otherwise they could be excommunicated. So there were very public supporters, but there were also very silent supporters. And ultimately, I think the fact that the president fought for it, even at risk of developing enemies. So actually, he developed enemies in the Catholic Church. But yes, I think the spirit of fighting for something that's necessary, which galvanized the whole country, not just from around the cities, but even in the far-flung provinces. I think it was, they say it's the first law in the Philippines that was so discussed broadly, that was so debated. So even the drivers knew what was being discussed. This was the kind of discourse around the reproductive health law.
So I have a question for Dr. Junice. It's a question, I guess, about, we're so grateful that you are here with us today, and I know everybody in this room will, speaking on my own behalf anyway, we get so much out of hearing you speak about your work. So it brings a lot to us to have you come to Canada and to be hearing about this work. But I'm curious, because I know you're here for a week. You've been to Canada before. I know one of your colleagues, Kiko, was here in Canada last year, and he did the human rights training course in Montreal. And I know that that through our work, Interpares and Likhaan, we've been able to set up some exchanges with groups in other countries too, like with some of the health workers in Burma. And I'm just curious, sort of, as you do your work at Likhaan, when you have these opportunities to be in a different country and in a different context, how do those experiences like influence and affect your work when you're back at home with Likhaan?
Actually, we learn a lot from whatever meetings, whatever forums. Of course, the priority for us always is the national struggle. And that's why when we are occupied there, even if there are very important and very interesting conferences elsewhere, we do not go. But I always, when I go to a meeting, whether this is the meeting or whether it's a New York meeting, where actually we fought with the Vatican over family values, it's these kinds of battle actually resonate. They actually are also issues that we talk about. When I attend a conference on quality of care, when I attend a conference like this one, learning about the Canadian system, learning about your law that needs to be revived or extended, the accord. I think it's a learning thing. I don't know if you've learned from me, but I definitely learned just listening to Mike here. And even the conversations that I have, I think there's a wealth of information that filters to me and to people like me that are very actively engaged in the movement there. Then for sure it will reverberate. Whatever information is there that's relevant to our situation there, we will also use that. So it's that kind of a two-way thing that I think is very important, especially for young people. And I'm glad that Kiko was here. Kiko actually took a human rights course here. In the Philippines, we know human rights by sense, by heart. We know exactly what we're striving for, and we strive with all our passion. Kiko went home, actually, and talked about the concepts behind. And that was a learning for many of the young people that had no conceptual training about human rights. So it's something, exchanges like this are something that we value very deeply for the movement there.
I have a question from Bill.
Hi, yeah, I'd like to thank our speakers. It's been a great evening. About a year ago, I found myself in Toronto, and I found myself about midnight at the East General Hospital, accompanying a family of they had claimed refugee status. Their claims were had just been denied, and they had a young daughter about 5 years old who was quite sick. They went to a pharmacy, and the pharmacist said, "You need to get her to the hospital." So they went to the East General Hospital. So it was about midnight. When we were there, we were told that they would have to pay $800 up front before they could have a doctor see the young girl. And I suddenly thought, where am I? This isn't my country. I don't recognize this. Eventually, we argued with them in the hospital and said, look, they don't have money, and they eventually had to sign a document saying that they would pledge that they would pay. They would commit themselves to paying for this. So I guess my question is to Mike, if you could talk a bit about the erosion of healthcare services for refugees, for asylum seekers, for others in Canada, because, yeah, it really was something that I just didn't recognize my country anymore.
Thank you for that question, Bill. That is a major sea change. I guess it's about a year, is it, that they attacked the Federal Refugee Health Program, a program that went back to post-World War II for displaced persons. It's a very symbolic program, exclusively federal jurisdiction. And as you know, most of you know, the vindictive comments from the Minister of Citizenship at the time, Jason Kenney, who has leadership aspirations to succeed as Prime Minister, basically called everyone cheats. And these are officially recognized refugees. It was so outrageous, the stuff on his website. Basically trying to revert a tradition of compassion to one of contempt. was a serious attack on the very fabric of civilized behavior. And the good news is the reaction from the physicians who are frontline dealing with clientele in those situations. Phenomenal. It's like almost like a general strike because they're not following that edict. And increasingly provinces are stepping in and saying, we'll cover that. But you're right, it's shocking scenario. But the good side is there's a lot of resistance. I've never seen frontline physicians be so political. They ambushed 6 ministers in press conferences to the point where a conservative minister is not safe in a public health facility because the physicians will ambush them on cuts to refugee health. So, and of course, we need to get those programs back. It may take a change in government.
So I'm going to take a question from Bessa and then from Mike, and we'll see how we're doing on time.
Just wondered if you'd comment on the CMA, the Canadian Medical Association, and where they stand on this.
Where they stand on refugee?
On Medicare and what's happening to it.
Oh, the good news is I think everyone's on the same page. We were at a meeting briefing Justin Trudeau, and there was about 16 national organizations. Every single one of them was on the same page in terms of federal leadership, home care, pharmacare, stable, predictable funding, transforming the system to phase 2. There's been some really positive developments in the Canadian Medical Association in the last number of leaders. They're no longer reflecting this commercial entrepreneurial view of Brian Day, that the recent presidents have been committed to social determinants and they're very strong on federal leadership. So that's quite encouraging.
I just wanted to ask generally about so much of the struggle seems to you about the competition between the people who want it to be all of an individual's responsibility, whether it's a moral responsibility not to have sex unless you want to have children, or if it's about the individual responsibility to go off and to have private insurance and to push for private responsibility for all of the health costs, versus the community side of, we all live and work together in communities, and if we are working towards collectively trying to go off and improve our health as a community and work towards looking at the community impacts, that we're likely to be more healthy as individuals if our communities are healthier. Is any of that it's hard to go off and deal with these kinds of debates, but and a lot of these are based on ideology between the right wing and the left wing. But there do seem to be some really solid numbers out there to go off and indicate that by working in community, and that there's less distribution of wealth between the richest and the poorest, that you're going to have a healthier population, the more equal people are. Is any of that sort of stuff resound within Canadian population or in the Philippines? Is anyone talking about the distribution of wealth and the how healthy we are as a society and as individuals?
The distribution of wealth is a big issue actually in the Philippines. The communist movement in the Philippines that is still alive until today is actually fighting for a redistribution and equal distribution of wealth. And it's true that the inequality permeates even the healthcare system. The healthcare system reflects a lot of the inequality, the gap between the rich and the poor. But those of us that work with healthcare as the site of change believe that health cannot just be a simple reflector of inequality and inequity, that it can actually be a tool so that you prioritize. For example, you know that poor people need services the most, or the most marginalized, whether it's women, whether it's elderly. You know that there are populations that are more vulnerable so that our feeling there is that the health system should do its own social justice position for the patients, so that the inequities are stopped at the healthcare system, and the healthcare system actually can be like an affirmative action kind of a system. So that's what those of us that are trying to do reforms with the health system. We're not just saying that automatically if there's inequality outside, then that it's normal that you would see the inequities also in the healthcare system. So health reform in the Philippines, when we say that the values of social justice and human rights should permeate the health system itself. Otherwise, we will not be able to respond to the needs completely of marginalized citizens.
I mean, I think the research in the last 100 years has definitely confirmed what you're saying. I think there was also a study that shows that people use different parts of the brain depending on your politics. And I think there's like a virus that's infected the Canadian imagination to think that health is individual and that all things come from the survival of the fittest. That's a very, very foreign concept. And we would not have survived with that ethic, literally, especially on the prairies. So it's a question of survival. It doesn't work. Even millionaires cannot survive a catastrophic illness. Superman went bankrupt, and they had to have charity fundraisers to pay for his health care. So it doesn't work in health. The ideology breaks down, does not apply. Nobody can get through this on their own. So it's an ideology, but it's not part of our makeup, and we have to fight to stop the spread of that mentality. I don't know if it's coming from Texas, if it comes up reverse through the pipeline, I don't know, but it's a very strange notion which we need to defend against.
So perhaps we all need to become doctors against this very particular virus, and start giving out these little pills that look like buttons that say, Canada needs a health accord. I think that we'll wrap up here. I want to again thank Dr. Junice, who is, you can't really tell, but she is about 12 hours ahead of us. And it hasn't really acclimatized yet, so you've done remarkably well. Thank you for getting up on stage with us. And thank you, Mike, for coming on a Monday evening and sharing with a group of Canadians who clearly care about the international, but also care about our local communities and about one another and want to see what your button says, to have a vision of Medicare 2.0, and also for that to trickle down and to be shared in other countries as well. I'll thank again the Douglas Caldwell Foundation, who helped bring Dr. Junice here and who helped us with this event. And thanks to all of you for coming. We really appreciate the community support of being able to meet with our supporters and our friends and our family. And it's been a wonderful evening with you this evening. So we'll leave it there. Thanks again.